Hi, sorry, we are now having a little technical issue. Our chairperson can't enter this Zoom meeting. We are waiting for her, so please sit for a while and have some tea first. Yeah.
Hi, Prof. Prem Kumar.
Hi,
Welcome to our webinar.
Dr. Calvin.
Yep.
Thank you for giving me this opportunity to just address everyone. My name is Prem Kumar, and I'm based in Penang. I'm a neuropsychiatrist in private practice, and I'm one of the members of the College of Physicians. Our president, Dr. Sri Paras Doshi, felt it would be a good idea if you all met some of us during your weekly webinars. And the reason we are basically conducting this is to disseminate medical information that's relevant to specialties. And I would like to commend the organizers and those who are behind the scenes for this wonderful effort. So please carry on with the webinar and have a good afternoon. Thank you again.
All right. Thank you, Prof. Prem Kumar, for the introduction. Good afternoon, everyone. Welcome to our weekly webinar organized by the College of Physicians Malaysia. The theme of the month is dermatology. And for today, our chairperson is Dr. Suganti, but she's having some issues to enter the webinar. Just hold on for a while.
Can you hear me now?
Yeah, hi. Welcome, Dr. Suganti. We just started the webinar. Yeah.
Started already, yeah?
Yeah.
Okay.
So just a few words for your introduction. Yeah. Okay. Dr. Suganti is a consultant dermatologist currently serving as the deputy head of department at the dermatology department of Hospital Kuala Lumpur. She obtained her membership in MRCP in UK in 2009 before graduating with a Masters of Internal Medicine degree from in 2010 and subsequently Advanced Master of Dermatology from UKM in 2015. She then did a stint at Sri Raj Hospital, Thailand in skin laser surgery. She chairs the Malaysian Psoriasis Registry, the main credentialing and privileging committee for medical aesthetic practice, Ministry of Health Malaysia, and was recently appointed as the subcommittee for education for dermatology subspecialty at the Malaysian Medical Council. As an educator, she trains postgraduate students in dermatology and serves as an adjunct lecturer for Masa University. She has published in various fields in dermatology and is actively involved in industry-sponsored research. Without further ado, let us welcome Dr. Suganti.
Thank you very much for your kind introduction. So this week is our third series, and today we have none other than Dr. Lim Aying. Dr. Lim Aying is a consultant dermatologist currently practicing in Hospital Teluk Intan. She's also involved in training of medical students as well as postgraduate students involved in the family medicine program and also the masters. Okay, so today she's going to talk to us about skin manifestations of connective tissue disease. So without further delay, let us welcome Dr. Lim Aying.
Thank you so much, Dr. Suganti, for the kind introduction. Thank you, the organizing committee, for the invitation. So please allow me to share my slides. So it gives me great pleasure to be able to talk to you on this topic of skin manifestation of CTD. So at the end of this lecture, I hope that you will know what is defined by connective tissue disease, what are the types under this category of disease, and how do they present. So CTD is actually a group of disease involving the protein-rich tissue, which supports our organ as well as other body parts, and it often involves joint, muscle, as well as the skin. But it may also involve other systems like the heart, lungs, and blood vessels. So under the umbrella of CTD, there are actually two main types. First is the inheritable ones, and the second type is autoimmune causes. So under the group of heritable CTD, examples are like Ehlers-Danlos, epidermolysis bullosa, Marfan, as well as osteogenesis imperfecta. Whereas under the category of autoimmune CTD, examples are like polymyositis and dermatomyositis, RA, scleroderma, Sjogren, SLE, vasculitis, and MCTD. So I'll be sharing with you each and every one of them, and the slides are mostly pictures so that you can get a clear pictures of them. So the first category that I'll be sharing with you will be the heritable causes of CTD. So firstly, Ehlers-Danlos, after this I'll mention it as EDS. It has more than 10 variants, with each of them having different genetic, biochemical, as well as clinical difference. And EDS involves genetic defect in collagen, connective tissue synthesis, as well as the structure. But although there's so many variants of it, a unique appearance of the skin is common to all of them, whereby patient will have pale and soft skin with a doughy feel. They have visible blood vessels located on the skin, and they have hyperextensibility of the skin. So these are the pictures to show you the clinical presentation. Also on the left, patient has an abnormal ability to elevate the right toe, and this patient has a scoliosis. And on the picture on the right, the fingers are able to be dorsiflexed easily without any pain. So how do they present in terms of skin? Fragility is very common with frequent bruising as well as lacerations. They have poor wound healing, and because of that, the use of suture is usually a problem among patients with EDS, whereby they have easy dehiscence of the wound, and they may end up with cigarette paper-like scarring, which are commonly found on the knees. So this is a picture showing you an obvious deformity on the left knee with cigarette paper-like scarring over the knees of these patients suffering from EDS. So molluscoid pseudotumors are actually small spongy tumors found over an area that prone for scarring and over the pressure points. So how do we diagnose a classical EDS? The patient must have at least the first major criteria, which is skin hyperextensibility and atrophic scarring, with either a second major criteria or 3 minor criteria, which I will present to you in a while. So the second major criteria is mobility of the joint generally, and more than 3 minor criteria of these 8, in which 5 of them are related to skin manifestation. So they will have easy bruising, they have soft, velvety, doughy skin, fragile skin, molluscoid pseudotumors that I mentioned just now, as well as subcutaneous spheroids. So second disease under the category of heritable cause is epidermolysis bullosa. I will mention it as EB from now on. So it's a group of bullous disease characterized by blister formation in response to mechanical trauma. So this is because of absence of basement membrane component due to genetic mutation. So there are 4 categories under the group of EB, whereby EB simplex is due to intraepidermal separation occurring over a higher level, whereas junctional EB is actually separation in the lamina lucida, which is the second layer. So dystrophic EB is separation under the lamina densa layer. And lastly, Kindler syndrome is extremely rare. It's a blistering that can occur at any level in this diagram that I show you. So first we go to EB simplex. The localized type can also be known as verbal cocaine. It's the most common form of EB simplex. So blister usually precipitated by a a very obvious traumatic event. So most common over the areas with trauma, like on the feet. Whereas the generalized type can be subdivided into the intermediate as well as severe subtype. Both of them typically present with a generalized onset of blister that occur either during birth or shortly after birth. So how do they present? They often have this hyperkeratotic skin over the palms and soles, which is related to blister that heals with atrophic scarring. So this picture shows you palmoplantar blistering as well as hyperkeratotic skin. So this is a close-up image showing hyperkeratotic papules and plaque on the palms after healing of the blister. So the second type is the junctional EB, where the split is actually at the lamina lucida level, and the subtypes of them of this category includes the lethal type, the non-lethal as well as the generalized type. So the lethal type is also known as severe generalized junctional EB. It's characterized by very severe blistering at birth and is related to a defect in this laminin 332 protein. So the lethal form of junctional EB is characterized by very severe orificial erosions around the mouth, eyes, and the nose. So a lot of times they are accompanied with very significant hypertrophic granulation tissue. So this is a picture showing you a child suffering from junctional EB, the lethalist type, where they have very generalized blistering at birth, and it often confers very poor prognosis to the child. So the third type of EB is the dystrophic EB, where it is because of a deeper layer at the sublamina densa, which is a defect in the anchoring fibrils. So the blister often healed with dystrophic scarring, with milia formation because of destruction to the hair follicles. So there is a dominant and recessive inheritance pattern. So this picture shows you nail dystrophy and loss as a result of dystrophic EB. And this mitten hand deformity that you can see on the hands and feet of this child is related to the dystrophic type of EB. So lastly is Kindle syndrome. Is characterized by EB-like blistering, also induced by mechanical trauma, usually starting at birth or infancy. So the skin of a patient suffering with Kindler often heals with atrophic changes similar like the junctional type of EB. But as they approach late childhood, the blistering become less prominent, but they will have a more increased incidence of poikilodermatous changes on the photo-distributed area. So poikilodermatous skin changes include skin atrophy, hyperkeratosis, as well as telangiectasia and pigmentary changes. So like you see in this picture A, this child has got a very significant telangiectasia on the face with thickening of the skin. And there's also mixed picture of hyper and hypopigmentation. So the location of the lesions actually occurred over the sun-exposed area. So third disease under the category of heritable CTD is Marfan syndrome. It's a genetic defect of connective tissue with autosomal dominant mode of transmission affecting the FBN1 gene. So this disease usually affect more commonly musculoskeletal, cardiac, as well as ocular system. So skin manifestation often may present among the people with Marfan syndrome, although it is non-essential for the diagnosis. So among these patients, striae may develop even without any significant weight gain or pregnancy. So striae tend to occur over the area subjected to stress, for example, over the shoulders, hip, buttock, as well as the lumbar region. So this picture on the left shows you striae over the shoulder, and this adolescent patient having multiple striae over the lumbar region. So the fourth group of disease under heritable CTD is osteogenesis imperfecta. It's a genetic disease of connective tissue caused by type 1 collagen problem, which is typically found in the bones. So because of that, OI is also known as brittle bone disease. So patients suffering with OI often have increased susceptibility to bone fractures as well as decreased bone density. So there's 11 types being identified so far. So clinically, the patients suffering with OI will present with blue sclera. They will have poor dentines. Often they have short stature as well as they may develop deafness during adulthood. There are also reported cases of valvular insufficiency and aortic root dilatation among these patients. In terms of skin manifestation, a patient with OI may have generalized laxity of skin. They will have easy bruising as well as excessive sweating. So this picture shows you easy bruising and also bony abnormality that occur in a patient with OI. So now we come to the second part of my presentation, which is about autoimmune type of CTD. So the first that I'll be talking to you will be on polymyositis and dermatomyositis. It's an idiopathic inflammatory myopathy characterized by skeletal muscle involvement as well as skin changes. It's quite uncommon. The incidence may go up to 6 per 100,000 population, affecting women more. So children can also be affected, and this subtype is called the juvenile dermatomyositis. So adult onset dermatomyositis is very strongly associated with malignancy, most of which are adenoCAs and also nasopharyngeal carcinomas. So skin manifestations of dermatomyositis are basically classified into 6 categories. So I will go through each and every one of that in a while. So the clinical cause of dermatomyositis skin lesions do not necessarily parallel to that of the severity of muscle disease, and it may occur either before or after the onset of myositis. So when you encounter someone with these pathognomonic signs on the skin, then you can quite confidently say that this patient could be suffering from dermatomyositis. So Gottron papules are actually violaceous scaly plaques that occur over the knuckles on the hands in the MCP joints. Gottron sign is when the violaceous papules or plaque occur over the extensors of the limbs. In this case, this is over the elbow. And heliotrope sign is a very classical finding that you can see over the periorbital region where there is violaceous macules around the periorbital region. So apart from that, characteristic signs of dermatomyositis may also include Holter sign, which are violaceous scaly papules that can coalesce into a larger plaque over the proximal thigh. This feature can also be noticed over the scalp and over the photo-distributed area where this is occurring over the shaw area, nape of neck and upper shoulder, as well as the V region of the neck. So besides that, neopho changes is also one of the characteristic skin manifestation in people suffering with dermatomyositis, where in this neopho capillaroscopy, the red arrow is actually showing the capillary hemorrhage, whereas the green arrow is showing you abnormal morphology of the capillaries with dilatation. And this blue arrow is showing you cuticular dystrophy. So in a nutshell, there's often overall disorganization of the capillary bed in a patient with dermatomyositis. So compatible signs of skin manifestation includes poikiloderma changes. So like I mentioned just now, there is often a mixture of hyper and hypopigmentary changes on the skin occurring along together with telangiectasia as well as skin atrophy. So picture on the right shows you this lady is having periorbital edema as well as facial swelling as a result of dermatomyositis. So the less common skin manifestation of dermatomyositis includes ulceration. So when you see an ulceration, often you need to suspect patient may have associated anti-MDA5 antibodies where they have a higher tendency to develop interstitial lung disease. So besides Patients with dermatomyositis may also present with vesicobulous lesions. They may have vasculitic lesions, and vasculitis is more commonly seen among the childhood age group of dermatomyositis. So calcinosis cutis is a condition where there is collection of calcium in the subcutaneous tissue, and sometimes it may cause ulceration. So the rare manifestation of skin in people with dermatomyositis may include mechanic hands. So as seen in the picture, you can see hyperkeratotic papules joining to become a larger plug on the palmar aspect of the fingers. So this phenomenon is seen more commonly in patients with anti-MDA5 and also anti-synthetase subtype of dermatomyositis. And again, both of these are associated with an increased risk of interstitial lung disease. So follicular hyperkeratosis is actually very thick hyperkeratotic papules that distributed over the follicular openings. So this is seen in the Wong's type dermatomyositis. So that chair sign is a rare manifestation. So there is actually sparing of the skin, which is being obliterated. So you can see here the patient has generalized erythema, but when patients stretch up the body, you can see sparing of this abdominal fold, what we call that chair sign. So patients with dermatomyositis may also rarely present with erythroderma, in which they have more than 90% involvement of the body surface area, which are inflamed and also very red. So mucinosis is another rare manifestation of dermatomyositis, where you can see on these pictures, there's symmetrical plaques on the limbs formed by coalescence of small violaceous papules. And mucinosis is because of dermal mucin deposition. Panniculitis is another rare manifestation, where it presents as tender erythematous subcutaneous nodules. Often you need to pinch it to feel it. So they may also have oral mucosal changes. So like in the picture A, there's marginal edematous gingivitis, which is believed to be due to capillary changes among people suffering from polymyositis or dermatomyositis. So picture on the right shows you telangiectasia over the gingiva. So we move on to rheumatoid arthritis. As we know, it's a chronic systemic inflammatory autoimmune disease characterized by symmetrical destructive type of polyarthritis, and often they will have extra articular manifestation, including skin. So the skin changes under RA can generally be classified into 4. So firstly, general cutaneous manifestation. Secondly, RA-related skin disease, followed by RA-specific disease, as well as adverse cutaneous reaction because of treatment. So we'll go through general skin manifestation first. So people with RA often may manifest with atrophic skin with easy bruising. So they may have pale and translucent skin over the dorsum of hands, and they may also have very dry skin which is termed xerosis. They can have palmar erythema as well as Raynaud's phenomenon. And often nail changes can also be seen among patients suffering with RA. So they may have brittle nails, they have onycholysis, which is termed by nail bed separation distally from the nail bed. They may also have clubbing. So ventral pterygium is shown in these 2 pictures. It's actually proliferation of the hyponychium, this part of the tissue, which continues to attach to the distal portion of the nail plate. So eventually this condition will cause obliteration of the nail groove here. So RA-related skin disease are skin condition that may have a link with RA, but can also occur in other conditions. So examples are like neutrophilic dermatosis, including Sweet syndrome and pyoderma gangrenosum. Granulomatous dermatitis is also one of the RA-related skin condition that patient may have. Besides that, they may also have livedo reticularis Zika syndrome. So RA-specific skin manifestation, so one of which is rheumatoid nodules. So rheumatoid nodules can present as either solitary or multiple skin-colored nodules on areas with recurrent pressure or trauma. So for example, on the fingers, elbows, as well as the heels. So sometimes these rheumatoid nodules can go up to a few centimeters in diameter. But generally, they are asymptomatic, although some patients may have complications like ulceration to the nodules, leading to infection. So rheumatoid nodulosis is a condition affecting male patients ranging from the age of 30 to 50. So clinically, it usually presents as multiple self-limiting rheumatoid nodules, and they run a benign course. But patients having rheumatoid nodulosis, they may develop classical erosive type of RA. Accelerated nodulosis is a condition where there is a rapid onset of multiple small nodules occurring over the hands and feet in people who are treated with systemic agent. So it affects up to around 10% of people taking methotrexate, or less commonly like Arava, azathioprine, and even TNF inhibitors. Rheumatoid vasculitis is another RA-specific skin condition where it is an unusual complication of long-standing severe RA. So typically involving the small to medium-sized vessel. So the vasculitis present as palpable purpura and also nail fold infarcts as shown in this picture. So it occurs over the nail fold. So picture on the left shows you vasculitic rash with necrotic ulcers over the knuckles. And pictures on the right shows you the typical palpable purpura that we see in people suffering with vasculitis. Rheumatoid neutrophilic dermatitis is another rare manifestation of RA. So it usually happens in very severe long-standing seropositive RA where they present as symmetrical asymptomatic eruption of erythematous papules, nodules, and plaques. So sometimes they may arrange in a annular distribution, means it's rounded in shape. So the third disease under the category of autoimmune CTD is scleroderma. So it's an autoimmune fibrosing disease that can be classified into either the localized type by the name of morphia or the systemic type. And under systemic sclerosis, there's either limited or diffuse cutaneous systemic sclerosis. So this table shows you the differentiating picture in between the localized type as well as the diffuse type. So in the case of systemic sclerosis, usually patient will have a presence of Raynaud's phenomenon. They have sclerodactyly, nail fold capillary involvement. They will have a positive ANA. They may have GI association and also cardiopulmonary complications. And because of that, they will have an increased mortality among patients suffering from systemic sclerosis. So of an important note, morphia does not usually become systemic sclerosis. So comparing the limited and also the diffuse type of cutaneous systemic sclerosis. So the limited type usually involve area which is distal to the elbow and knees. So as shown in this cartoon, they may involve face, but most of the time they involve area distal to the elbows and knees. Whereas in the diffuse type of cutaneous systemic sclerosis, they generally involve the whole body. And people suffering with diffuse cutaneous systemic sclerosis will have early onset of Raynaud's phenomenon within 1 year of sclerosis. And the autoantibody involved in diffuse type is the anti-SCL70 as well as polymerase III antibodies. And complications that patients may suffer will be lung fibrosis, GI disease, even renal disease, as well as cardiac fibrosis. So how do they present in systemic sclerosis? So this is a long list of them, which I will go through with you, each and every one of them. So cutaneous sclerosis is actually tightening of the skin. So sclerodactyly is as shown in the first two pictures, where you can see progressive tightening of the skin causing deformity to the fingers. And acro-osteolysis is a phenomena where the distal phalanges become mutilated because of bone reabsorption. So microstomia with perioral puckering is also commonly seen among people suffering with systemic sclerosis due to sclerosis of the periorbital soft tissue. And this lady actually has a mask-like faces because of the sclerosis of the facial skin. So Raynaud's phenomenon is also commonly seen among people suffering with systemic sclerosis, where these triphasic changes of pallor, when they first exposed to cold temperature, will be followed by cyanosis. And upon rewarming, the fingers will turn into erythema. Cutaneous ulceration is another common presentation in people with systemic sclerosis, where if the ischemia is over the digits or finger palps, it's often because of vascular impairment. But if there is ulcers over the DIP as well as the PIP joints, it is often due to stretched fibrotic skin and skin breakdown due to trauma. So calcinosis cutis, I've mentioned it earlier on, is deposition of calcium in the subcutaneous tissue. So this X-ray is actually correlating with the clinical finding where the calcium deposition is being highlighted in a radiograph of the patient. So this calcium deposition may ulcerate and discharge chalk-like material which consists of calcium phosphate and calcium carbonate. So these are examples showing you calcinosis cutis on the digits as well as on dorsum of the feet. Next is cutaneous telangiectasia. So it is actually defined by dilated dermal capillaries seen mostly on the face. Of course, it can also be seen over the neck and also other body parts, including trunk and also the limbs. So this picture shows you matte telangiectasia, in which the dilated blood vessels are flat and also square-like clusters. Nail-fold capillary alteration is also one of the common features being seen among patients with systemic sclerosis, where the scleroderma pattern is actually related to microangiopathy. So I'm going to show you the pictures of these changes. So under the normal circumstances, you can see that the capillary bed is actually arranged in a very orderly fashion, whereby during the early phase, patient may have enlarged and giant capillaries, and during the active phase of the disease, there will be hemorrhages seen and disorganization of the microvascular array. And during the late changes, apart from hemorrhages, they may also have this condition called capillary ramification, where the capillaries present like bush-like. So next, they may also present with cutaneous pigmentary changes, where this salt and pepper dyspigmentation is the most characteristic feature. So picture on the right shows you the salt and pepper dyspigmentation occurring on the chest. So besides, patient may also have an Addisonian type of pigmentation where it occurs diffusely, more on the sun-exposed area. So this is another picture to show you the salt and pepper appearance of this pigmentation. So we have finished with the systemic sclerosis. So now we go to the localized the sclerosing type, which is morphia. So morphia is characterized by excessive collagen deposition causing thickening of the dermis as well as subcutaneous tissue. So symptoms are usually limited to the skin and the neighboring tissue involved, but not the internal organs. Yeah. But having said that, because of the extent of the involvement can go up to bone, it may sometimes cause very severe disfigurement as well as deformities of the extremities due to the very deep fibrosis. So the first type of morphia is known as plaque morphia. This is the more common one. So during the early inflammatory stage, you can see there's a violaceous plaque with an erythematous rim, which we call it as a lilac ring. And later on, they may go on to become a ivory-colored indurated plaque. So atrophoderma of Pacini and Parini is one of the subtype of localized sclerosing disease. So in these pictures show you that there's multiple symmetrical and hyperpigmented sharply demarcated patches that ranges from in their sizes. So there's also another subtype by the name of generalized morphia, where there is multiple coalescing indurated plaques that occur mainly on the trunk, legs, and also the lumbosacral region in a symmetrical pattern. So when it comes to generalized, patient must have at least 4 lesions, each of them more than 3 centimeters and affect more than 2 anatomical sites. So this picture shows you example of generalized morphia where you can see that the diameter is more than 3 centimeters, definitely, and it occurs over different area of the trunk as well as the limbs. So another subtype of morphia is this disabling pansclerotic morphia. It's most debilitating form, but it's quite rare. Usually can be seen during childhood. So it's characterized by disabling very widespread circumferential skin distribution with significant involvement of the subcutaneous tissue, fascia, muscle, as well as bone. So the fibrosis often result in severe contractures, causing limitation of joint mobility. And sometimes the large ulceration with necrosis also increase the risk of development of squamous cell carcinoma. So these are pictures showing you examples of disabling pansclerotic morphia, where you can see that the skin is severely fibrotic and is very diffuse. So another subtype of morphia is eosinophilic fasciitis. So it's actually a mimicker of cellulitis. So if someone presents with you with recurrent cellulitis, poorly responding to antibiotics, and you cannot find an obvious source of infection, so need to suspect this entity of disease. Yeah. So eosinophilic fasciitis often has an acute onset that presents with painful, symmetrical swelling of the extremities. So it does not involve hands and feet. So in the later stage, when the fasciitis goes on and on, the overlying affected areas may become indurated, leading to a typical port orange appearance due to thickening of the fascia underneath. So this is the example of eosinophilic fasciitis, where you can see this groove sign, which is the linear furrows overlying the veins. And this can be more pronounced when the patient elevates their limbs. So linear morphia is another subtype of morphia. It is more commonly seen among children, up to 2/3 of the cases. So it presents as either single, linear, and unilateral bands of atrophy and furrows following these lines of Blaschko. So the picture on the right shows you the typical lines of Blaschko that we see in a normal individual. So linear morphia involve more over the lower limbs than other body parts like upper limbs and also even the head and neck area. So there is a special entity of linear morphia where they have this sclerosis happening over the frontal or frontal parietal scalp, resembling the cut from a sword. So this entity of morphia is by the name of Coupe de Sabé. So it can be associated with scarring alopecia if scalp is involved. And also patient may present with neurological manifestation like seizures and facial paralysis and even neuropathy. So pictures on the right shows you the example of Encode Disabe, where you can see the line, the linear line of sclerosis over the frontal scalp as well as the forehead. And pictures on the left show you a linear morphia involving one side of the lower limb following the lines of Blaschko. Peri-Rombert syndrome is also another subtype of morphia, where the synonym is actually progressive facial hemiatrophy. So it's a variant of linear morphia involving the head and face. So this disease actually has a slow and progressive unilateral atrophy of upper face involving the frontal and maxillary dermatomes. And because of the involvement of muscle and bones, it may result in very severe facial asymmetry, as well as association with neurological impairment. So this is actually a series of pictures showing the chronology of patients suffering with Peri-Rombert syndrome, where at the age of 2, there's hardly any abnormality seen on the right side of the face. But starting at 5 years old, there's already a subtle changes over the right side of the face. And at that adolescent age, you can see very marked atrophy of the right side of the face. And as the patient progresses into adulthood, there will be very severe involvement with the bones as well as subcutaneous tissue. Up next is Sjogren syndrome. So it is an autoimmune disease affecting mainly the secretory glands of eyes, mouth, causing sicca symptoms. So common skin manifestation in patients suffering with Sjogren may include dry and also rough skin. We name it as xerosis. So they may have a lack of sweating, hypohidrosis, vaginal dryness, and even small vessel vasculitis and also urticaria vasculitis. So this is examples of picture showing xerosis cutis, where you can see somewhat like a fish scale type of skin dryness. So this is an example of small vessel vasculitis, where there is palpable violaceous purpura on the feet. And this is an example of urticaria vasculitis, where the patients may present with wheel-like lesion. So up next is SLE. So under the Gilliam classification, skin manifestation in SLE can be either specific to lupus or non-specific. So when we call it as LE specific, it is where histologically we can see changes of interface dermatitis, where else in the case of LE non-specific skin manifestation, the biopsy may not show a classical interface dermatitis. So this is the Gilliam classification of skin lesion associated with lupus erythematosus, where we have the specific type and the non-specific type. So my focus today will be on the LE specific type, where that consists of acute cutaneous LE, subacute cutaneous LE, as well as the chronic cutaneous LE. So I'll go through most of them with you. So under acute cutaneous LE, there's 2 types. So firstly, the localized acute cutaneous LE, or another term, mala or butterfly rash. So the second type is generalized acute cutaneous LE, where it can also be called as photosensitive lupus dermatitis or lupus rash. And there is a variant of it called TEN like ACLE. So the subacute type, we have annular SCLE as well as papular squamous. And under the umbrella of chronic cutaneous LE, there is discoid LE, hypertrophic, and so forth. I will go through with you in a while. So in the case of acute cutaneous LE, so this is the very commonly described butterfly and mala rash. So it's actually a localized form of acute cutaneous LE. So note that in this picture, the nasolabial folds are spat. Yeah. So generalized acute cutaneous LE often present as a widespread morbilliform or exanthematous eruption over the extensor aspect of hands, arms and hands, because they are sun exposed area. And characteristically, these rashes often spare the knuckles. So as a contrast, I mentioned to you dermatomyositis, the violaceous plaques actually occur over the knuckles, but in the case of ACLE, it will spare the knuckles. And patients may also present with perivascular neophoerythema and telangiectasia in the case of generalized acute CLE. So I've mentioned to you about this variant of TEN like ACLE. It's an extremely acute form of ACLE that is rarely seen, and it simulates the TEN due to drug allergy. So this results from widespread apoptosis of keratinocytes, and eventually patient may develop a full thickness skin necrosis, and they will subsequently peel off, just like the case of TEN due to drug allergy. So how can it be differentiated with the true TEN is that it occurs predominantly over the sun-exposed area. And the mucosa may or may not be involved. Like in the case of TEN, 2 mucosa have to be involved. So these are the series of pictures showing you the example of TEN-like ACLE, where there is widespread erythematous papules with some vesicles and bullae seen over the body and upper limb. So there's severe epidermal loss and denuded skin on the face. And there's also painless palatal ulceration, which is characteristic of SLE. So subacute CLE, often there's a finding of circulating autoantibodies to Rho or SSA antibodies. So SLE usually presents as erythematous macules or papules that they will slowly evolve into hyperkeratotic papulosquamous or annular plaque. Again, it's mainly over the sun-exposed area. So picture on the left show you the annular pattern of SCLE on the upper back, where you can see central area of hypopigmentation. So papular squamous, almost mimicking like plaque psoriasis. So it is more commonly seen over the sun-exposed area. So now we come to chronic cutaneous LE. So the most common one is the classical discoid type of LE. So it begins as red to purple macules or papules that slowly will develop into a hyperkeratotic plaque. So it typically will evolve into a sharply demarcated coin-shaped erythematous plaque covered by adherent scales. So often it may go on and finally leave behind atrophic central scarring, telangiectasia, as well as hypopigmentation as the end result of the lesion. And often follicular involvement is a prominent feature. So this is an example of a classical discoid lupus where there is a erythematous margin. Okay. So you can see there is multiple sharply demarcated round to ovoid shaped erythematous plaque on the neck region of this patient. And the periphery actually is showing hyperkeratosis and some degree of dermal atrophy at the center. So this is a classical ear sign that we often describe in people suffering with discoid lupus, where it characteristically affects the concave of the ear as well as the outer portion of external auditory canal here. And scalp is quite commonly involved in discoid LE, up to about 60% of them. And unfortunately, because of the follicular involvement, patients often suffer from irreversible scarring type of alopecia from such involvement. So the scarring alopecia that the results from the discoid lupus actually is different with the lupus hair that we usually encounter in people with acute SLE. After acute flare, they may have telogen effluvium and sudden thinning of hair. But this sort of hair loss is usually non-scarring as compared to the discoid type of LE where patient will suffer from scarring alopecia. So discoid LE can also occur over the mucosa, where in this picture there is palatal involvement where you can see that the morphology is similar like those on the skin. Okay. So second type of chronic CLE is the hypertrophic type. It's a rare variant of chronic CLE where over the sun-exposed area, the hyperkeratosis becomes very exaggerated. These are another two pictures to show you the exaggerated hyperkeratosis over the sun-exposed area. Mucosa DLE is another example of chronic CLE, and it affects up to 25% of people with chronic CLE. So oral mucosa is by far the most commonly affected ones. And in this picture, it shows you the plaque is actually very sharply marginated, and it has an irregular scallop white borders with white striae in the middle. So this picture shows you a palatal ulcer with central depression. So if this goes on without treatment, it may degenerate into squamous cell carcinoma in the long run. So chronic discoid lupus can also occur over the vermilion border of the lips. So as shown in this series of pictures, there is a diffuse cheilitis, especially over the more sun-exposed lower lip. And discoid lupus can also affect many other mucosa surface, including nasal, conjunctiva, as well as anogenital mucosa. So conjunctiva discoid lupus affect more on the lower lip than upper lip. So it often begin as a focal area of inflammation affecting the palpebrae, conjunctiva, as well as the lip margin. And after that, scarring become evident as the lesion mature and without treatment. So in the end, patient may suffer from permanent loss of eyelash, and eventually the eyelid may turn outward, become ectropion, and causing considerable disability. So the next subtype of chronic cutaneous LE is LE profundus or panniculitis. It's a rare form of chronic CLE typified by inflammation occurring over the lower dermis and the subcutis. So LE profundus is termed when patient has both panniculitis plus a typical discoid lesion above the area of panniculitis, whereas LE panniculitis is only the subcutaneous being involved. So this is a picture showing you lupus panniculitis resulting in multiple large sunken area of erythema and atrophy. So chilblain LE commonly present as purple red patches or papules on the digits and precipitated by cold and damp climates. So as the lesion evolve, they may have the scarring and atrophic plaque. So this is a picture showing you chilblain lesions affecting the fingers in a patient with long-standing SLE. So this can even occur without co-exposure. So LE tumidus is another variant of chronic CLE where they will have classical dermal findings in histology, but because histologically the epidermis does not have typical LE specific disease, that's why they do not have epidermal changes present clinically. So they have more of a urticaria-like edematous form of presentation. Like in this picture, the plaques on the face appeared as succulent indurated plaques, but there's actually lack of epidermal changes. So up next is vasculitis. So leukocytoclastic vasculitis is a small vessel vasculitis characterized by immune complex mediated vasculitis involving the dermal capillaries and venules. So cutaneous vasculitis is usually confined to the skin. Rarely it may have extracutaneous manifestation, but not more than 30% of the case. So the key findings in vasculitis manifestation is a palpable purpura and involvement of the lower extremities. So these are a series of pictures showing leukocytoclastic vasculitis where there is violaceous palpable plaques on the lower extremities. So under the Chapel Hill consensus published in 2012 for vasculitis classification, there's small, medium, and large vessels. But in the context of leukocytoclastic vasculitis, usually is involvement of medium and small vessels. So under small vessels vasculitis, there's actually either ANCA-related or immune complex-related. There's also variable vessel vasculitis like Behçet and single organ vasculitis, like listed here. Systemic disease is where I've mentioned repeatedly here in this lecture today, like lupus vasculitis and rheumatoid vasculitis are the examples of CTD-related vasculitis, and also vasculitis associated with various other etiology like hepatitis B, C, and even syphilis. So the last topic that I'm going to share with you today will be on mixed connective tissue disease. It's a rare autoimmune CTD with positive UIRNP antibodies. So the clinical features of MCTD actually consists of among three more commoner CTD, including SLE, systemic sclerosis, and polymyositis. So patients with MCTD may have prominent neophocapillaries that I've shown before this. They will have small vessel vasculitis and also erythematous plaque that resemble discoid LE. So these pictures on the left shows you facial erythema that may be seen in patients suffering with mixed connective tissue disease, and the erythematous plaque that resembles discoid lupus. So patient may also suffer from scarring alopecia, where you can see the hair follicles are obliterated. That's why there will be no new hair growth. So they may also have a diffuse non-scarring type of alopecia, where you can see generalized thinning of the hair without atrophy of the hair follicle opening. So to conclude my presentation, skin being the largest organ in our body, it serves as a window to our general well-being as well as window to systemic diseases. So by recognizing the skin manifestation, it will definitely aid in diagnosing the various type of connective tissue disease. And I hope the lecture today will help you with empowering your knowledge and recognition of the disease. Thank you.
Okay, thank you very much, Dr. Lim. That was a very comprehensive lecture. Okay, so I don't see any questions in the chat box yet. We all know from your lecture that you have shown that connective tissue disease actually cover a very wide variety of diseases, okay, with such variable presentation. And this actually can be quite a challenge to actually diagnose and treat these patients, okay? And to complicate these things, sometimes we also have patients who overlap with the connective tissue diseases. And in dermatology, we also know there are many mimickers, okay? So it's very important that sometimes this skin is the first manifestation of the connective tissue disease. So it's very important that we recognize, diagnose correctly, so that we can actually treat these patients early. Okay, I still don't see any questions. Do put your questions in the chat box or question and answer box. We'll probably give a few moments if there are any burning questions to the participants. Okay, if there are no questions, I think I then hand it back to the chairperson. Thank you.
All right. Thank you, Dr. Lim, for the wonderful talk, and Dr. Sugati for chairing the session. Thanks, everyone, for participating in this week's webinar. We will see you next week. Goodbye.
Thank you.
Bye-bye.